Hi, Delmar-Bethlehem EMS. I'm Bruce.
And I'm Matt.
And today, we're going to pump up your RMAs.
Hello again. Doc Bruce and I have two cases for you tonight that we want to talk about. The first case, the call goes out. It's a 22-year-old female, diabetic in a local shopping plaza. She starts to feel weak, diaphoretic. She is a seasoned diabetic. She was diagnosed when she was about 2 years of age. And because she's a seasoned diabetic, she has some orange juice with her. So she starts to take that and takes her blood sugar. It's about 40. In the meantime, a bystander sees her sit down, thinks that she's not feeling well. She goes to call 911. By the time that EMS gets there, we chat with her, we get her history, we take her blood sugar. It's in the 80 or 90 range. So now the question is, what do we do with the paperwork? She's adamant that she doesn't want to go to the hospital. She doesn't want to be transported. She's had diabetes forever. So the question is, what do we do?
Our second case is a little bit different. You're dispatched to a 70-year-old male with a history of COPD for shortness of breath. You arrive on the scene, you walk in the door. From the doorway, you see a gentleman sitting bolt upright. You see the oxygen tubing in the corner, which the patient's not wearing. You see two different puffers laying on the bed. And the patient says, I don't want to be taken care of. I smoke cigarettes. I've been smoking cigarettes for many, many years. I don't want to go to the hospital, and I don't want you to care for me. Thanks. I didn't call you. Just go home. So what do you do with that case? Well, the first thing I would do is explain to the patient just how sick he is and say, look, you're sweating. You're not able to speak in full sentences. If we leave and don't care for you, there is a really good likelihood that you could die. And do your best to build a rapport with the patient and try to convince him to at least allow you to start some therapy. Explain to him that if you just leave, you are very concerned that he won't see the light of day. So what do you do if you do your best, you try to bond with him, he still says, no, I don't want to go to the hospital, no, I don't want to be treated by you? Well, in your conversation, you have to determine capacity. Does he have the ability to say no? Does he understand the things that you're saying? Did you explain the risks to him, and does he actually understand those risks? For example, his breathing could become worse, his oxygen level can continue to drop, and that he needs to be compliant and wear his oxygen. Lastly, if you really can't win, does he know he can call you back? Just because he says no right now, does that really mean he can't call you back? And the answer is no. If he changes his mind a little while, he can call you back. And there's another piece to this before you walk out the door. You want to call a base station physician. Anyone can call a base station physician. EMT, intermediates, paramedics, doesn't make a difference. The important part is it's a recorded line, and you want to not just talk to the physician yourself. After painting a picture of what you've been doing with this patient, you want to then hand the phone over to the patient, and the doctor can talk with the patient. And we'll go through basically the same things on a recorded line that you did. The physician will see if he agrees with you on your assessment of capacity. Can the patient refuse care? He's going to go through what are the options, if there are any other options. If the person's only speaking in 3- and 4-word sentences, the options are truly limited. Lastly, at the end, he'll explain he can't force you to go, but he strongly suggests it, and we'll say, if you change your mind, please call back 911. We'll be more than happy to see you.
Bruce was just talking about the 3 pillars of an RMA and why those are important and necessary. The question is, why are we doing this? What's the point of this whole video that we're putting together? I looked back at about 6 months of data recently and found that of the 35 RMAs that we've done, only one of them had all 3 of those pieces correctly stated in the chart. And at the end of the day, whether or not you intended to or it's your fault, if something bad happens, it's a lot easier to blame the EMT.
Wah, wah, wah.
So the key here is that we want to figure out a way, and we wanted to communicate a way to try and make your RMAs better, and more robust so that you're covered and we as an agency are covered as well.
Okay, so we've been talking about RMAs, but we haven't actually defined that. It stands for refusal of medical advice. Around the hospital, they call it against medical advice. But in our region, we use RMA, or refuse medical advice. That can be refusing part or all of the care or transport. A person has the ability to say, yes, I'll take that oral medication, but I don't want an IV. Or, no, I don't want you to treat me at all, but I want you to take me to the hospital. Or the other way around. Yes, I want you to do everything you can for me at home, but no matter what you do, I am not going to the hospital. All that is permitted as long as the patient has capacity. And that is the first key pillar, is to determine, does the patient have capacity? Next pillar, pillar number 2, is understands risks. Not just that you've told the patient what the risks are, but that they understand those risks. They have capacity, so they're understanding things, but you have to explain it in a way, in their language, that they understand. You can't use all that nice medical jargon that you learned in EMT school. You need to put it at the level of the patient, and that varies, as you know. So get them to understand, what are the risks. The risks are variable based on what the disease process is. In the setting of the diabetic, her risk is her sugar go down and she could pass out while she's driving. But she understands that, and she knows how to prevent that. In the case of the second patient with the COPD, that person's pH can rise, they can stop breathing, they can die. You need to explain that to the patient, and you can have them pair it back to you. You can tell by the way that they're responding to you with their eyes, or if they're looking off into space and not really comprehending. You have to make sure that you understand, the patient understands, what is the risks. The last pillar, the third pillar, knows can call back 911. Very important, if the patient changes their mind, that bad COPD, or it's getting tougher and tougher for him to breathe, put on his oxygen, took his inhalers, he's still getting harder and harder to breathe, says, all right, I better call back 911, because some people, if you don't say, hey, look, we'll come back if you call back, will think, oh, I refused, I can't call back 911, and that's just not true. If they call us back an hour later, we'll be there for them. So to go over it again, the key pillars: has capacity, understands risks, knows can call back 911. See how brief that was? That's exactly the way you should document it on your PCR. Has capacity, understands risks, knows can call back 911. You're certainly welcome to write more, but you need to get those 3 key pillars in every PCR. Thank you very much for listening.